Adnan Mirza, and Dr. Adnan Mirza is joined Khan University Hospital in 2019, and before that, he was working as a senior consultant neonatologist and a pediatrician, equivalent to assistant professor on academic post, and acting head of department of NICU, Dr. Suleiman Al Habib Medical Group, which was 452 bedded hospital, teaching hospital at Saudi Commission of Health and subspecialty for 6 consecutive years, and also having the 19 years of experience of pediatric practice with subspecialty training in the neonatology from Ireland and Saudi Arabia and to Pakistan. He have written numerous articles and case reports on the neonatal and cardiac cases and general pediatric topic of the interest, and published them in peer-reviewed journals. Beside these, there are almost 20 abstracts, publication, oral, and the poster combined internationally, and also recently 3 poster acceptance in the research day conducted in the AKUH in this month. His professional journey with Khan University Hospital is still on every day, and every day he grows with the institution. Currently, Dr. Adnan Mirza working as a consultant neonatologist and director neonatal fellowship program, director NICU quality team, and the coordinator ophthalmology and the program coordinator neonatal cardiology sick babies at Khan University Hospital. Over to you, sir.
Oh, Bhajan, thank you very much for such a generous introduction. Thank you. I'm quite humble for this. Thank you very much. Let's start because the time is nearly there, 8 o'clock. And what we discussed today is basically what are the probiotics history. International Scientific Association for Probiotics. What has been said about this topic, which was controversial a decade before, but not now. I want to tell more about the listeners about the common use and perception of probiotics for the NICU. I want to delineate the myths and the wrong concepts about the probiotics through this presentation as much as I can. Once we go forward, we will talk about systemic review and the recent meta-analysis for the neck in regarding of probiotics. I will try to include all the studies and literature, including the Lenses PIP study, that has a very important role in making the literature and the policies for the probiotics. We will discuss about the guidelines, which are quite controversial, and they are multifactorial as well. I will include the NHS guideline and Danish guideline for the uses of probiotics. In the end, we will recall the presentation and take some take-home messages. So let's start with this first slide. The general concept of probiotics came from a Russian scientist. His name was very difficult to pronounce. Sorry for that. His name is Laurie McIntosh, who postulated that the yogurt consuming Bulgarian peasants, they lived longer. यानी कि life longer होती है because of their custom. He postulated this in 1907, that the dependence of the intestinal microbes on the food that makes it possible to adopt measures to modify the flora in our bodies and to replace the harmful microbes by useful microbes is very important in the use of probiotics. From that time, the history of probiotics gave us special attention. We have received renewed attention recently from product manufacturers, research studies, and consumers also. There was a lot of questions about what are probiotics. This is about a decade before, not now. But from that time, the history has started. And the history of probiotics can be traced to the first use of cheese and fermented products that were used by the Greeks in the past. The Greek people, and still now, the fermentation of dairy foods represents one of the oldest technique for food preservation, and that was done, and that was investigated, and that was proven fine since long time. The burning question, what are probiotics for all our new fellows, is the current definition is they are the live organisms that survive in the anaerobic environment of our gut. As we all know that our gut is very sensitive also, but the probiotics are very also sensitive for the oxygen, the heat of the human body, and the moisture. After all these controversies from 2001 to 2014, the International Scientific Association for Probiotics and Prebiotics generated a consensus treatment in 2014, and they said the panel is convinced that sufficient evidence has accumulated to date, that is in 2014, that the concepts of core benefits of certain probiotics is reasonable to expect that evidence gained from a defined class of live microbes might be appropriate for certain but not all health outcomes. What they want to say that until 2014, there are many indications where the people were using the probiotics, like in asthma, diarrhea, colic, even in skin allergies. So they said the panel is convinced until that time that we should start investigating and start making the policy for the appropriate use of probiotics for not all, but in some outcomes. To make it more easier, I want to tell you this slide that was presented on that meeting in 2014. There are four stakeholders: the scientists. They have all of them have interest, but the interest of scientists was they want to generate a high quality science that has positive impact on society. This is a general concept of scientists. Our industry, that is the pharmaceutical industry, they want a high quality, profitable products with validated and understandable claims that the product will do this or product is useful for that. At the same time, there are some committees like the same as Pagan committees and regulatory committees. They want to protect the consumers from misinformation. And finally, the consumers, they want reliable information to make the informed decisions after all these previous which I have discussed. So what actually will happen? They proposed that what are the general mechanisms of probiotics. They divided that in that meeting into three: the rare, the frequent, and the widespread. The rare strain specific effects were neurological effects from probiotics regarding the soothness, sleep disorders, improvement, immunological effects like lack of allergies, just like Montelukast, endocrinological effects like growth hormone effects, potentiation, and production of specific bioactives. Examples are prebiotics. These are the rare. The frequent effects which are seen through probiotics are species level effects. I will discuss in further slides. There are a total about 18 probiotic species, and some of the effects are species specific, strain specific, and dose specific. The frequent effects by species will be vitamin synthesis, gut barrier reinforcement, and etc. and etc. The most common and widespread among studied probiotics causes colonization resistance. That is, we are interested at the moment. They will regulate the intestinal transit time and used in many diseases of adult and neonatal intestinal, like neck, normalization of perturbed microbiota, and increased turnover of enterocytes. As we all know, today the topic of discussion is protection of neck through probiotics. I will try to show you from coming slides that how it is benefited for the necrotizing enterocolitis. The overall framework for probiotics products among the markets are they can be used in the drugs, medical foods, non-oral probiotic foods, animal feeds, etc. and etc. So here, now we are after 9-10 slides, we will take a look at the 18 best probiotic strains that are in the market. The basic and the prominent one are Bifidobacterium and Lactobacillus, and they all have further 6 or 7 species. You must be confusing that which strain we should use. Apart from the literature and the pharmacies, the best one is the Bifidobacteria, which are the dominant strains in the infancy period. The studies proved when we combine both of them, a bifidogenic effect will generate by their combination, which causes a kind of fermentation process that is responsible for all the probiotics effects in the human body. The other issue comes, as I discussed previously, shall we use monostrain or multi-strain? The evidence indicates and proves that when we use the multi-strain and the multi-species, it is far more better and more effective once you use the monostrain. And I will try to show you with the evidence in the coming slide. All these references from the evidences are down in each slide. Similarly, the question comes at that time what dose it should be given. There was no general consensus until 2014, and there were about 18 studies and many randomized controlled trials which were using different doses. But evidence indicates that for the probiotics to be function or to be more effective and to be more viable, a sufficient dosage level is required between 10 to the power 6 to 10 to the power 7 colony forming units of that particular product. Currently, there is no further data available regarding a dose beyond we can find out that high risk, extremely low birth weight neonates showed the less risk of probiotic complication, if there is any. But as I say, that in London, in the expert meeting, they suggest that once you use and start the probiotic from the 10 to the power 5, oh, sorry, 1 to power 1.5 by 10 to the power 9 colony forming units a day, they found it better when the feed reached about 50 to 60 ml per kilo per day. But that's not the end of the story. If you go to the literature, you will find the people have started the probiotics as early as 4 hours of age. And that was done by Sethard, who has studied in 10,500 premature infants and proven that it was good to use them it was okay to say and safe to start at 4 hours of age. Now the probiotic supplementation should be started as early as possible before any bacteria colonize or any antibiotic destroy the prevailing commensals of the intestine. But at the same time, we all have to be very careful that the baby should be clinically stable and he should not be having or she should not be having any signs of bad sepsis, culture proven sepsis, or hemodynamically significant PDA that alters the gut ischemic response. And so the desirable outcome for the probiotic have not been reached. And this is the main reason why the general consensus of probiotic use and doses has not been achieved yet is because of that not the dose specific, is the patient specific. Every baby we discussed before as well is different. Not all of them have PDA, and then not all of them have hemodynamically significant PDA. At the same time, not all of them bad sepsis. Similarly, not all of them are compromised. So once you have a baby who's on inotropes and compromised, the effect of probiotics in that particular baby is slightly different, and we should not even use it. At the same time, if that baby comes out from that particular disease, the effect is different too. Before going further, we will go to the specific thing that what the literature say about the probiotic use in the preterm babies. So I'm lucky to be part of this study that has been done by Jassim and Abris when I was in Saudi Arabia, and Khalid Al Fail, who was my supervisor in my fellowship as well. And they proved there that enteral supplementation of probiotics prevents severe necrotizing enterocolitis, and the mortality in the preterm infants if it was used in the babies that we were enrolled at that time, which were less than 37 weeks of gestation, more than 34 weeks of gestation, and they were less than 2.5 kilo. What the systemic review and meta-analysis said about probiotics. I tried to get all the information from Cochrane, Lancet, New Reviews, and this, and I will try to show you this all. So one of the study done done by Gori, that probiotics for the prevention of necrotizing enterocolitis in preterm infants. There were 26 studies and meta-analysis were included in this one, and they found out that probiotics have an overall preventive effect in the preterm infants that suffers with NEC. Similarly, one of the study done by the Sherry showed that if you use the probiotics in those NICUs who have higher rates of necrotizing enterocolitis, you may be able to get the more benefit effect than the one who are not having high incidence. It is quite similar to the use of antifungal, which is recommended to be used in those NICUs who have high incidence of fungal infections. Similarly, they found out that the multi-strain probiotics, which I did tell you before as well, is more effective than single-strain products. At the same time, they recommend there is no standardization of the policies for not only for the use, for the dose, but also for the storage, preparation, distribution, administration, and documentation of probiotics. I want to emphasize here and let the audience know this, that probiotics are live organisms. If you do not store them well, the probiotics may not be that effective that they should be. And that is one of the main concern, the variation in the effectivity of probiotics among the whole RCTs. The storage problem and the distribution problem too. Going forward, what the Cochrane said. The Cochrane, in one of the thing, 24 eligible trials were included. What I'm just giving you the conclusion here. That and the baseline risk for NANEC in the control groups, timing, and all was postulated. And they found out the probiotics preparations containing either lactobacillus alone or in combination with bifidobacterium were effective in prevention of neck and preterm babies. And that is the point which we have been discussed before as well. About 5,112 preterm were included among all these 24 studies. If you go back to the probiotics and sepsis, and that is a burning question because they are the live organisms. Do they not? Are they safe? Do they cause sepsis? So this is one of the trial done in China by a famous university, Nanjing Medical University, and they said if you assess the major risk of probiotic use, the mortality and sepsis were compared between probiotic and placebo group in their analysis, which they report the 14 trials, and they found out there was no significant heterogeneity among the trials, which is a quite significant statement that sepsis may not be directly related to the probiotics, but may be compensated. This is one of the largest study, and it gained a quite a higher impact, the PIP study, and they included about 1,300 babies with a randomized controls trial, and study is published in Lancet, where they say they did not find any complications associated with giving probiotics, including sepsis. But at the same time, they did a blanket statement by saying that neither did we find any evidence that the probiotic that we give protect the babies from neck sepsis or death. That was quite strange. the, the studies that were done between 3 years from July 10 and July 13, they mention that if you use the combination bifidobacteriogenic effect by using the multi-strain, the effects of probiotics was much better, and the probiotic associated adverse events will not be there. So at one stage, I'm showing you very positive, and at one other stage, I'm showing you the blanket statements as well. At the same time, there was no evidence of benefit for this intervention in the population which they studies to support the use of single bacteria for the probiotics. Up till now, we conclude that there are two major species that can be used for the probiotics. And at the same time, we conclude that there is still controversy that shall we make it as a total guideline or policy for the unanimous use or not. Just go back further. I just want to say something that I have learned until now, that everyone wants to live on the top of the mountain, but all the happiness and growth that occurs when you are climbing. Going back further towards the evidence-based guidelines for the use of probiotics in preterm neonates. Now we are continuing our topic, and I try to convince the audience. I may not say that I try to convince. I say I try to open the mind for them that whether we should use the probiotics in preterm units to prevent the necrotizing enterocolitis. So what's the evidence say over here? The evidence indicates that the functionality of a multi-strain or multi-species probiotics could be more effective and more consistent than that of a monostrain probiotic. I did show you before. The results of one review only indicated that multi-strain probiotics showed greater efficacy than single strains, including single strains that were components of the mixtures themselves. It was unclear whether this was due to synergistic interactions between the strains or to the higher probiotic dose used in some studies. And this question is still not been answered. All this evidence I have been shown in the previous slides. Coming back to the burning point, which guidelines use? You all will be surprised to see that these are the guidelines. I'm sure you all be confused. In 1997, Kijama used 0.5 by 10 to the power 9 colony forming unit once daily from first feeds for 28 days. Then in Danny 2002, 6 into 10 to the 9 colony forming units once daily from first feed until discharge. Now he didn't mention until what gestation discharge. Costeros uses 10 to the power 9 per kilo twice daily for first days for 30 days. I don't want to go further, just want you to see the variation in the probiotic protocols. And that was the time when in 2014, and you can see the years, they're all 4, 3, 5, 6, 7, 9, that the committee has been formed and decided to make a decision about the unanimous use of it for the particular procedures, for the particular diseases, and for the unanimous use of the dose. The statement was role of probiotics in probiotic products. At the same time, there was some argument, not argument, there was some study that shows if we use probiotics along with the coexistence prebiotics, it will find the better. The coexistence of probiotics found to be better in human breast milk too, and there was a synergistic effect. Just for the people who are joined now, that the Danish guidelines were found to be very famous in those time of 2011, and their policy was to give the probiotics once a day to all infants who completed less than 30 weeks of who has completed the less than 30 weeks of gestation starting from the third day of life. And as per them, if their neonates has used 1 ml of milk per meal or more, they add the probiotics in them. Their plan was to continue the probiotics until the discharge from the hospital. And this was their policy, and this has gained enough popularity in 2010. That's why I choose to use over here. These are the NHS guidelines for the use of probiotics. And they use the combination. Their indications are for neck and also for the prevention of neck. And this was in 2015. The NHS guideline have used multiple probiotics strains and their preparation that contains bifidobacterium and lactobacillus alone, and they found it very, very effective. They do long-term follow-up of their data, and they found out there is no significant side effects. The study was done and published in Cochrane, and they studied about 5,000 babies. And they were very positive about this. Until now, what we have discussed, let's recall quickly so the people understand that who joined late that how probiotics works here, that they improve the intestinal barrier function of a neonate or infant. They do modulate the immune system in a better way than without probiotics. They do suppress the growth or epithelial binding invasion of the pathogenic organism. This is a general effect of action. What the evidence say more about it is randomized controlled trials and systemic reviews have demonstrated that probiotic therapy reduces the rate of the neck. And those neonates who receive probiotics versus control were less likely to develop the harsh and severe stage of neck, which is stage 2 or higher, as per Bell staging. Those neonates who do not receive probiotics had a lower mortality rate as well. Who receive probiotics have a lower mortality rate too. And there was no difference in the rate of nosocomial sepsis. This is an important line. There was no difference in the rate of nosocomial sepsis between the infants who receive probiotics and the controls. There is a single follow-up study that says that, which is a systemic review, there is no difference in the growth and neurodevelopmental and sensory outcomes between the probiotic and place groups at the 3 years of corrected age. Just a second. If you do the summary of all the products and effects of the probiotics, you can see over here, the probiotics have been studied extensively among 10,000 infants. And on the right side over here, if you see my arrow, there are about 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12 studies with the patients in nearly all are more than 5,000. And all of them utilize a wide variety of bacterial stains. But the most common one were bifidobacterium and lactobacillus. The results of these studies have fixed means they have only one positive coming. This means fixed effect. I repeat, the results, if you see the last column, they have effects. There are two things written over there, the random effects and the fixed. The fixed effects means they're all positive, and the random effects mean most of them positive and some of them have negative results too. So the conclusion of all these trials were, despite this clinical heterogeneity, the cumulative meta-analysis of the studies shows a strong treatment effect of probiotics in the reduction of neck. And this is the pooled treatment effect of probiotics. You can see on your left side, the OPS means observational studies and RCTs are randomized control studies. All of them are showing favorable for probiotic use. And the pooled treatment effects of probiotics on neck, death, and late onset sepsis in the clinical trials have been similar to those in observation studies. True, though there was a statistical heterogeneity in all the studies, but most of them were favoring the use of probiotics in reducing the necrotizing enterocolitis and thus the mortality and the death. When you do the individual trials and observational studies of probiotics reporting a significant reduction in neck, nearly all of them, I say yes, they do decrease. So this is the recent literature of all the evidences that are important in reducing these neck pictures by the use of probiotics. The largest implementation cohort study to date was involved by the use of Lactobacillus acidophilus and Bifidobacterium infloran. This is the product name in Germany. And it's a very famous, which is usually using in Middle East and USA as well. And all of them favoring the use of the neck. This slide showing the product by, there's a name of BioGaia, Infloran, ABC-Dophilus. I have used about 4 of them in my life. And they are just showing the survey that the 16 different commercial products are available in different NICUs of United States. And the most common product accounts were the same strain, the Lactobacillus and Bifidobacillus, which is the commonest one. The idea of showing all these slides are that the multi-strain effect, multi-strain probiotics with a bifidogenic effect are the most common one using in all the literatures, which found that the neck is preventable and not preventable, has been reduced in those centers that use these kind of probiotics. Coming back to the safety of probiotics, there have been several case reports of probiotic-associated sepsis, mostly from Bifidobacterium longissime associated with the use of Infloran, and also some of them from one of the main product named Saccharomyces, which use the fungal probiotics. That's why in most of the NICUs, the use of fungal probiotic is not getting very popular, and actually they are not using much due to the risk of late onset sepsis and death. What I want to conclude here, that a large number of preclinical studies provide mechanistic insight into how probiotics support the gut health and how they decrease the necrotizing enterocolitis when they have been used in early stage or late stage. These results support the beneficial effect of probiotic observed in meta-analysis of both randomized trials and observation studies, as we show previously as well. But the overall effect on neck is unlikely to change substantially given the large number of trials and babies studied to date. So the overall effect will remains the same, but a little bit more in favoring of using of probiotics in prevention of neck. What are the recent suggestions? These are the recent suggestions by Tendro Mori, who has wrote multiple books in this topic. He said that some experts suggest that probiotic therapy should be offered in the locations. Locations means in the countries where they are licensed or available by special access to the infants who meet the eligibility criteria. Like they are not being sick much, they have no signs of sepsis, they have no compromised gut through due to PDA, and they have no complex congenital heart disease. And the published trials support them. And there is an adequate quality of control for the administered product. This is a very important point. The probiotics are the live organisms. If they go there in a safe and healthy temperature control environment, their efficacy is more better rather than if they're on the shelf and the efficacy is much lesser. The other suggestions are that this is by the Kigman, and he has a good control and about 6 studies in the literature. He suggests that the current use of probiotics will be limited to the clinical trials until the most effective regime for premature infants, especially the low birth weight, is identified. This is this sentence has now little bit more favor towards the bifidobacterium or lactobacillus. So people understand that these strains are better. So he put it this statement in 2005, but recently this statement has been governed by the use of bifidogenic effect of lactobacillus and bifidobacterium. One of the included studies in the meta-analysis from Taiwan reported the high rate of sepsis, and that study used about 8,000 babies to comment on this. So it is very prudent for them to wait for further clarification and risk benefit analysis before routine use of probiotic therapy in preterm infant, and if you recommend them. One of the included, sorry for that. Now we go for the take-home messages. After all the little bit of controversies which I discussed in the past few slides, that the selection of the strains combination containing lactobacillus and at least one bifidobacterium species is preferable than using lactobacillus gauri alone, which may not be effective. And this is the first take-home message and has level 1 evidence. Dose 3 by 10 to the power 9 organism per day, preferably in a single dose. Again, this evidence turned out to be a level 1 evidence if you use this is a kind of descriptive evidence and is a weak evidence. When to start? When the neonate is ready for enteral feeds, preferably within first 7 days of life. It has both parts, level 1 and level 3. That this evidence is obtained from well-designed control trials, but they are without randomization. How long to continue? At least 35 weeks characteristic gestation stage or until discharge. This is level 2 evidence. Supplementation during acute illness. We should stop the supplementation during acute illness such as sepsis, neck, or if the baby is suffering from hypoxia. And that's level 4 evidence, which has been confirmed by well-designed case control or cohort studies. The further take-home messages after this presentation is the researchers observed a significant, which is about a 50% decrease in the incidence of necrotizing enterocolitis without using probiotics to 5.4% with the probiotic use. This is a significant message to all of you who are listening today. Probiotics should be considered standard of care and used routinely to all preterm infants less than 32 weeks of gestation. It's one of the take-home messages because the neck is much more common in the babies less than 32 weeks. We may have additional studies comparing the strains and examining the additional NICU populations, possibly with the length of therapy that required to treat them. And this is again a blanket statement, how much additional you want to use. I think it could be gene specific, strain specific, population specific. There seems to be no further research to delay the introduction of this evidence-based therapy in ICU. What I want to say, the probiotics are safe to start. There's enough evidence to start using them if we are not using them in our NICUs. Probiotic supplementation in preterm infant is perhaps the best studied yet least used therapy in neonatal medicine. This is one of the lines which I took from one of the articles. And I really like the line, that's why I included this in the study. in my presentation. Thank you very much for listening, and I'm very happy to answer any questions.
Thank you so much, sir. Really, it was a very nice presentation. So here we have a few questions.
Mhm. I
Sir,
think I will
one
go.
question is, yes, sir.
At which
Sir,
temperature? You want me to answer now, or yeah? That I can. You want to ask the question, or I can see the questions here. What is your like?
so
You
as,
want me to read? Yeah, yeah, yeah. Please go ahead. Please.
okay, sir, okay, sir, okay, sir, fine, sir. So, question one is, at which temperature should we keep the probiotics?
Yes, this is a very important question, because many studies have shown that the efficacy of probiotic will be very less once the temperature is not maintained. I discussed this in my, I think, 36th slide. The temperatures for the lactobacillus acidophilus and bifidobacterium bacillus, which is the enfloran, the most popular used German made probiotics, maintained at a storage temperature of 4 degrees centigrade. I repeat, 4 degrees centigrade, which is generally not feasible in tropical and subtropical countries. That's why the effect of this medicine is lesser. This I'm talking about Enfloran. So there are other probiotics that has been used and exposed to some temperature countries, but for the Enfloran is 4 degrees centigrade. Thank you.
Right, sir. So, second question is there any role of uh, prebiotic in preventing neck?
I think
I think
pro लिखा
he
है
was
probiotic
prebiotic. हाँ,
probiotic
pro लिखा है. हाँ, sorry, probiotic. ये तो answer I think
अब वो तो हो
is
चुका है आंसर, इससे ज्यादा क्या बताए। हाँ, अगर आपका सवाल ये है कि प्रीबायोटिक्स डू द synergistic effect for probiotics. So I would say if you're using probiotic and you're using a combination with the prebiotics, the answer is very, very yes. But if you're only using prebiotics, I don't think so. This is any relevant of this question.
right, sir.
Okay.
So another question: does the probiotics FDA approved?
Yes. Okay. Yes. This is a good. The probiotics जो है, sorry, the FDA approved probiotics in the year. Just a second. I will 1 second. The FDA until now did not approve the probiotics. The reasons because of the claims for their safety. For the
Right,
safety.
sir.
That's
Yeah.
right. So
So,
there are, yes. Yes.
Said,
Yes.
Adnan, can I interrupt?
Yes. Please.
Sorry.
Yes.
Sure, sir. Welcome.
Okay. So the first question is, okay, FDA is not approved, so this is confirmed. Okay.
Yes.
The first question is that prebiotic or probiotic. That's the question.
No. There was a question, Dr. Junaid, that is there any role of probiotic prebiotic in preventing neck? The person wrote over there
Okay.
probiotic. We
Yeah.
understood
So
it. Maybe he maybe he wrote prebiotic. Maybe it
yeah.
seems like
So
yeah.
So the prebiotic, okay, has its effects, but not in preventing the neck. And the pre and pro combined together, it is called
Synergistic.
symbiotic, and which is
Yes.
a much better option. But the thing is that I don't know. Maybe I will keep it this for the last. That we should use it or we shouldn't use it. This is the key problem. Whatever the data you showed is fine, is there, but what is the concrete evidence, okay, that we should use in all the babies, and which size of the baby? If I miss in your presentation, you present which size baby you are recommending to use the probiotic?
Less than 30, less than 32 weeks and less than 32 weeks. The strong recommendation.
The less than 32 weeks, so it means
Yeah.
that less than 1.5 gram, okay,
Kilo. Yes, you're right.
where 1.5 kilo, okay.
And
So now
some literature say 2 kilo also. I want to
okay,
exactly.
so what the thing is that so you are giving only to prevent neck.
The
What,
point of discussion over today's presentation was use of probiotics for prevention of neck. So this was
yeah.
the presentation. Yeah.
Okay, so the thing is that I couldn't find, maybe some seniors. I think Dr. Haq is there. Naveed is there, can can jump into this thing that we still don't have. And then the thing is that the evidence is all over the place. Okay, some say strong recommendations, some say not, because of many reasons, which is not the point. So, did you discuss how probiotics prevent neck? I mean, do you discuss? Maybe I miss
Yes, yes, you missed
initially.
it. By
Like,
three, you want me to open that slide? I can just do verbally that it's by
okay.
immune modulation, by
Mhm.
epithelial enhancement for protection, and increase the gut barrier system.
So if we give exclusive breastfeeding in those babies, okay, it will not work, or it helps, because all what is the probiotic, because the commercially prepared probiotics are very different, and all of the studies is a very high, uh, I recommend one thing more, Adnan, that whenever you show the studies, show the forest plots, because there is a paragraphs you put it from some things. So the thing is that the heterogeneity in those studies are very high, because some
You want
use
to see
some
the forest plot? I want to show you now. You want to see? I have it done here.
no, there are 4 5 slides, which is very busy
Yes.
slides that I'm telling you. So go back
So
to the
this one.
forest plot. Yeah,
Yeah.
go back.
Oh, it is hang now. Sorry for that.
No problem, we have time. Okay,
Mhm.
so it's very good that we discuss all these
Yes.
issues, and all those things.
Mhm. I think yeah.
So this study, let's see, this is Danish guidelines. Is
Yeah. Okay.
so these are the guidelines. Okay, these are their own guidelines. Okay,
Mm-hmm.
I don't know what is the the neck rate there. Okay, and what what their what is the purpose of this guideline in their unit from.
The preference is to decrease the neck,
So what is the
and they
incidence
use
of
in
neck
less
in
than
this
30.
unit? What is
Well, to
the
be honest with
incidence of
you,
neck is what in their
incidence
unit?
of neck. Well, if you want, I can generate you this answer later on. But this is just a snapshot for the presentation that they use in the less than 30 weeks of gestation for the
I know,
prevention
but
of neck
this is
in
the
their
thing
unit.
that if we
Yeah.
don't
But if you
have
want
the
to
neck,
that deep, yeah, everybody have different incidents. You may have different. We have
no,
different, and it's
yeah, I know
multifactorial. Hmm.
exactly. So the problem is that my thing is that to give the give the thing that okay, we should use the neck, we should use probiotic. I think it is overstatement. We will
Hmm.
see the more thing, because we are not using in both of our unit in here or in USA, okay, and since long, so and we don't have any problem with the neck, because we are concentrated more on the this thing.
Rest.
So yeah, show me this forest plot, just 1 minute.
Yeah, I was just going there. Yeah.
So I think that there are few evidence which say, but I think we should have more this thing, that Dr. Sarup Chand, he want to ask some question until you are. Yes, go ahead.
Here's it. Yeah.
No, this is the yeah. So this is the first plot, okay, but here it's not giving everything, how much is the heterogeneity, what study, what is their, who did the study in which center. So this is the pooled, thing, but I think if you
Treatment.
put everything in the slide, then it is much better, much effective. Then this is the yeah. Okay. So anyway, this is a lot of discussion we can do about this. So let's say this OBS study is 60% I2. So it's too much heterogeneity. And then
Yeah.
it is almost 23% in the randomized control trial. Okay.
This is
So
what I
only,
mentioned as well. Yeah,
yeah.
if you see it in the right side, it's very well. I mentioned this is much
So,
heterogeneity among all
so
the trials.
exactly. So the effect of these trials are not very this thing. So anyway, this is from Germany, this is study?
Yeah, that's a German one,
Oh,
which
okay.
use infloran. Yes.
Okay. So let Sarup ask his question, then we can continue more.
Yes, Dr. Saru, you want to ask question? Any?
Dr.
Can
Khalid
you?
Haq, I can see. Yeah. Anyway, yeah.
Sure, we can ask Dr. Khalid,
If doc,
जी
sir.
जी जी
Yes,
जी
अस्सलाम
sir.
Assalamu alaikum, sir.
Walaikum
जी
salam. बिल्कुल बिल्कुल.
जी अस्सलाम
All right.
वालेकुम अस्सलाम
Sir,
वालेकुम
your comment, please.
yes
Please.
I will thank you Adnan thank you
नहीं नहीं कोई
for
बात
your presentation I enjoyed that
नहीं. Thank you.
for our younger colleagues I think let us make a couple of things very clear uh, probiotics as far as I know, the current status is that there's a big divide between practitioners in the United States and practitioners in Europe.
Yeah.
Probiotics are frequently used and recommended in Europe, whilst because of safety profile, they are not recommended and not used very much in the United States. That is number one. Number two, I think it's very important to remember that like any drug, probiotics have good effect and bad effect. And particularly if you're using, as you suggested, I think unfortunately, that multi-strain are better. No, multi-strain, if only two strains, if they contain lactobacillus and bifidobacter,
Yeah.
that particular probiotic is better rather than having 10 different strains, which are the content of most commercial probiotics. So number two is that if you're going to use probiotics, then use the product which contains only these two bacteria, which are the good bacteria, and the function you have enumerated. And number three, the question is, do they prevent NEC? The answer is debatable. We are not very sure whether probiotics can be used as a prevention of necrotizing enterocolitis, whereas indeed they have not been shown to affect the mortality or the outcome. So that is the debate whether probiotics should be used or should not be used. Lastly, I think you did not mention, unfortunately, the most recent editorial on it it is by Dr. Razak from Saudi Arabia,
Yes,
who has shown that there have been nearly 81,000 preterm babies studied in all the probiotic studies. And the answer is possibly yes, you should use it, but it can be debated. And I think there are no more studies going to happen, and each unit and each individual should decide whether and when to use. These are answers which are not available. What dose to use, when to start, when to stop, and whether they are really very, very effective or not. But yes, if you're using a good product, keeping it nice and in the nice temperature, then the complication of sepsis is much less. So I think we should be open to both rather than at this moment in time, as far as I am concerned, the debate is on rather than making a statement that it should be used. I'm not sure of that.
Exactly. So that's why my whole point for all the juniors that they can go to the to their pharmacy and then they start probiotics. No, stay tuned. Okay, the probiotics is debatable, and there are very new things, sir. You must review it. That when you use probiotic for a long period of a time, and the same thing, it itself can alter the bacteria. Okay, so this is very important. And what Dr. Haq said, that if you are use only two bacteria, because if you use multiple, it can again alter the bacteria, and it cannot prevent the preventive effect of the for the neck is gone. So we have to be very, very careful. If you have a less neck in your there is no need to go for this adventure. If you have promote the breast milk as much as possible, it can have much better effect than the probiotics. This is my take home.
जुनेद यू आर सो राइट. अब जो मैंने अपने एनईसी के लेक्चर में भी बताया था,
जी,
there is a balance which has to be maintained between good
Yeah.
and bad bacteria. If you have too much bad bacteria, you will be in trouble. If you have too much good bacteria, you will be in trouble. So
जी, बिल्कुल सर.
the dysbiosis has to be stopped, and there has to be a balance between good and bad bacteria in your gut if you're going to prevent diseases, intestinal related diseases.
Yeah. So similarly, like formula company comes to you, oh, we have probiotics, we have prebiotics, we have HMOs. This is all gimmicks. This is all commercial gimmicks. Don't fall into the trap. Okay. They are putting what bacteria, what probiotic, what prebiotic, you don't know. And the HMO, they call it human milk oligosaccharide. And it is not a human milk drive. It is synthetic in the labs. So these formula companies just, making it attractive for many things, but which has no effects, or maybe has a bad effect in a long term. So first of all, the breast milk is the thing. The probiotic, I have my own doubts. If someone want to use it, then it depends. There is a question that if somebody develop the neck, then it help. No, not at all. Okay. So don't do never do that. That if somebody already have neck and you given some extra bacteria, don't do that. Okay. So there these type of things I am afraid that in our country can happen if we use probiotic left and right. Adnan, I saw Naveed also. Naveed, do you have any comment? Okay, Saeed, if any
Yes,
more questions?
Here is
Or...
yes, sir. Here's more few questions. Yes, does the probiotics have beneficial effects if neonates on neonates on the top feed?
Again, my answer is the same. Adnan can add on that. There's no beneficial effect.
Right, sir.
I have the problem is that we go through this probiotic, this thing, heard of Dr. Joseph Nu, and he has a lot of thing, his article published in Time magazine about the microbiome also. I will find it out and I will send to all of you. So read it, that how
I
it is.
I have recently attended Dr. Joseph presentation in Saudi Council on webinar. I will try to share on the academic
Yeah,
group
yeah.
as
So
well.
what he said, what
On
is about
his-
probiotics?
Sir, actually, his final comment was that it is not recommended in USA.
Yeah, so that's the
Just more
thing.
than 90% have
It's
efficacy
not
issue.
the US and UK. Dr. Haq is very much right, because the dynamics is very different. Pakistan is different than UK and then USA.
Yes.
So that's a very important thing. Now the UK, I mean USA. First of all, the breast milk they are using. Then they have a donor milk. Then they have the formula, which is a human base, which is called Prolacta. So this is no baby is getting the formula nowadays there. So many of the units, this is very expensive one. This is a donor milk human based formula called Prolacta. And they are using in many of the unit, like big unit like Mayo itself, Texas Children, Baylor, all this. So they are more going towards the human milk or the donor milk if the breast milk is not available. Yeah, go ahead, Saeed.
Right, sir. So another question is, how do we calculate 3 into 109 organisms? I think they want to ask the dose.
Adnan can answer this.
Adnan, can you hear me?
Yeah, yes, I can hear you. I'm just listening to all the other people who are speaking. So if you give me a chance, then I speak. So the answer of this question is that the respectable person asked the amount of dose about the 10 to the power 5 or 10 to the power 9, how you calculate. Actually, when you use any probiotic product, they already have made it with the dose as per their own standard, and they make it like 5.2 ml or 2 drops or 3 drops like this. So when you take any product, the recommendation of their product is in their brochure. So you do not have actually yourself to prepare it or make it. You just use the product. And if your unit is policy, continue to use that as the per evidence of 10 to the power 5 or 10 to the power 9. At that time you modify their dose, which is easily happen once you use any product. It's not a problem for you.
यही तो प्रॉब्लम है अदनान कि neonatologist is dependent on the drug company to tell you the dose. You don't really know. Every product has a different amount of probiotic in it, and that is very difficult to standardize. So it's not like there's a huge problem with that, because every company and every product is different. And how do you when we use the blanket term probiotic, it is not like the blanket term of gentamicin. Each product is very, very, very different.
Dr. Haq, you are absolutely right. I'm not here to promote the probiotics.
No, I know that. I know that.
Inform you clearly.
Yes,
that
yes.
It's not recommended. It's not FDA approved. The point here was to use the probiotics in neck, yes or no. So I did my study, I did my research, and the forum is open for everyone. I'm not here to tell them to start probiotics and start using from tomorrow. This is very clear message.
Adnan, don't take it personally. It is an academic discussion.
Academic discussion नहीं हो रही है, उसी पे बात कर रहा हूँ मैं, तो आप ही लोगों की सुन रहा हूँ.